Assalamu alaikum. We will talk today about complication of chronic subarachnoid otitis media. We divide the complication of chronic subarachnoid otitis media into cranial complication, which occur in the temporal bone in which the middle ear cleft is present, intracranial complication or extracranial complication. The cranial complication may occur into the mastoid, which called mastoiditis, or in the petrous apex of the temporal bone, we will call it petrositis, or in the inner ear bone, we will call it otitic labyrinthitis, or in the facial nerve as it passes in the fallopian tube inside the temporal bone, which is called otitic facial paralysis. Regarding the extracranial complication, spread of the infection externally may cause otitis externa, or tracking of the pus may cause retropharyngeal abscess or digastric or Settling abscess. Spread of the infection to inside the intracranial cavity may cause extradural abscess, subdural lymphedema, meningitis, lateral sinus thrombosis, brain abscess, or otitic hydrocephalus. We will talk only in details about the cranial complication. Other complication is just for enumeration. At first, we will talk about mastoiditis. We remember these pictures or this diagram. Mastoiditis usually start by collection of pus into each mastoid air cells. So, instead of being consisting of multiple air cells or air-filled spaces, the mastoid will consist of multiple cavities filled with pus or multiple microabscesses. This we call the stage of acute mastoiditis. Here the patient will complain of severe ear pain. If we examine the patient, we will see congested tympanic membrane because the mucosa of the mastoid air cells is the same, the mucosa of the middle ear. Tender mastoid, if we try to put your finger on the mastoid tip, usually this is a tender mastoid. If we leave this patient without treatment, the multiple abscesses inside the middle or inside the mastoid process will coalesce together, forming a single large abscess filling the mastoid process. This is what we call the stage of coalescent mastoiditis. Here the patient will complain of also severe ear pain, congested tympanic membrane, tender mastoid, and ear discharge, what we call the reservoir sign. Why? Because if you find a perforation in such patient, this perforation usually will pour pus. If you try to suck or to remove this pus by suction or by a cotton tip, usually after removing or suction of the pus, immediately there will be another pulling of the pus into the external ear, and whenever you try to do suction for the discharge, you will find the perforation again will pour more discharge in the external ear canal. Why? This is because there is a large reservoir filled with pus. It's exactly like a reservoir with a water tape, and this water tape is dropping water. If you try to remove or to drying any water drop, the reservoir is filled with water, so it will pour another drop of water. It's exactly the same idea. You hear there is a large reservoir filled with pus, so whenever you try to remove the discharge, immediately there will be another pouring of more discharge. This is what we call reservoir. If you leave this patient without treatment, this abscess will more and more enlarge in size. It causes erosion of the cortical bone of the mastoid, and it will cause a cystic swelling beneath the skin over the mastoid process, and it will cause erosion of the bony external auditory canal or the posterior wall of the external auditory canal, and it will cause a bulge beneath the posterior wall of the external auditory canal. This is the stage of what we call mastoid abscess. And the sagging or the cystic swelling beneath the skin of the posterior meatal wall, this is what we call sagging of the posterior meatal wall, and it may even obscure the tympanic membrane. This patient will complain of severe pain, sagging of the external auditory canal of the skin of the posterior wall of the external auditory canal, obscuring the tympanic membrane. There will be tender, cystic, fluctuant swelling over the mastoid process, exactly like this. If we leave this patient without treatment, eventually the pus will cause erosion of the skin with trickling of pus from behind the auricle. This is what we call the stage of the mastoid fistula. Here, the patient will complain of severe pain, congested tympanic membrane, fistula discharging pus behind the auricle, as we can see here. This is the fourth stage of mastoid investigation. If you meet a case of mastoiditis, usually we'll ask for imaging, clean X-ray, or more recently CT, and etiological evaluation for preparing for surgery. Treatment usually consists of medical treatment and surgical treatment. For medical treatment, antibiotics that can cross the blood-brain barrier to guard against further intracranial complications. The best antibiotic that can cross the blood-brain barrier is the third generation cephalosporin. Usually we will use symptomatic treatment in the form of analgesic, anti-inflammatory, nasal decongestant. Surgery, we will do cortical mastoidectomy that we explained before in the last lecture. The aim of surgery here is to drain the mastoid, to remove the infected mucosa, to remove the infected granulation tissue, and to drain the accumulated pus in the mastoid air cavity. Petrositis is exactly similar in pathophysiology to mastoiditis. However, usually the petrositis will present with characteristic three symptoms: ear discharge, headache. Why? Because the petrous apex differ from the mastoid in its anatomical relation. The petrous apex usually is related superiorly to the ganglion of the trigeminal nerve and the thick cranial nerve which supplies the lateral rectus muscle. So in case of petrositis, the patient will complain of ear discharge, headache due to irritation of the trigeminal ganglion, convergent squint due to damage of the lateral of the abducent nerve, with corresponding paralysis of the lateral rectus muscle causing convergent squint. These three symptoms, ear discharge with headache and convergent squint, compose what we call the Gradinego triad, and this is a characteristic triad for any cases of petrositis. For otitic labyrinthitis, usually it starts as an infection in the middle ear. This infection in the middle ear causes erosion of the otic bone if it spread medially. This erosion of the otic bone eventually will cause an opening in the otic bone. This opening is a fistula communicating between the ear in the middle ear and the perilymph in the inner ear. This is stage what we call circumscribed labyrinthitis. Here the patient will complain of transient vertigo with nystagmus. This vertigo can be triggered by compress. Why? If you compress the tragus or if you pump air inside the external auditory canal with presence of perforation in the tympanic membrane, this positive pressure in the external auditory canal will be transmitted to the air in the middle ear. This will be transmitted through fistula to the perilymph in the inner ear. This will cause vestibular stimulation, so the patient can experience vertigo. This is what we call the fistula test, and this is what we call positive fistula test. Positive fistula test is diagnostic for what we call labyrinthine fistula. If you leave the patient without treatment, toxins of the bacteria will pass at first through this fistula into the perilymph, causing sterile inflammation inside the middle ear, or what we call serous labyrinthitis. Here, usually the condition will start to get worse. The patient will have continuous vertigo, tinnitus, sensory neural hearing loss due to affection of the cochlea. As we know, the inner ear function is hearing and balance. So, inflammation of the inner ear will cause disruption or interference with hearing or hearing loss, interference with balance. This is what causes the vertigo. Okay, so here will be vertigo, hearing loss, and tinnitus. But fortunately, if you can treat this patient well, hearing can be recovered and balance also can be recovered. But if we leave the patients, the bacteria itself can gain entry into the inner ear. Here, it will be not a sterile inflammation, it will be a pyogenic inflammation, or what we call subaurative labyrinthitis. This is more and more worse. So, there will be also continuous vertigo, tinnitus, sensory hearing loss, exactly like the serous type, but the main difference that here the condition is irreversible. Even if you treat this patient, you will leave non-functioning inner ear because the destructed outer hair cells and the vestibular cells will be replaced by fibrous tissue. So this patient will be left with non-functioning inner ear, or what we call the dead ear, called labyrinthitis ossificans. Treatment of otitic labyrinthitis consists of medical treatment of the cause, mastoidectomy to eradicate the infection. Then, after the conditions has been settled, usually we will search for rehabilitations of the remaining hearing loss. If the patient has remaining moderate or some kind or even severe hearing loss, we can compensate for such hearing loss using hearing aid. If the patient is left with dead ear with non-functioning ear at all, here we may think about cochlear implantation to compensate for this hearing loss. If the patient has experienced labyrinthitis ossificans, then we will have no spaces in the inner ear even to implant the cochlea, so even cochlear implantation will be not feasible, and in such cases the only rehabilitation could be the sign language.